morning, everyone. It's beautiful to see that there's about 2 and 10 and the numbers are growing. I love this. My name is Samia Abdi, and I would love to welcome you to our webinar for today, Support for Mothers with Borderline Personality Disorder. Again, my name is Samia Abdi, and I am a Senior Program Specialist at PHO. I lead the Health Equity File. And just to start us off, I wanted to recognize that I am joining today from Toronto, the traditional land of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, the Wendat people, and continues to be home to diverse First Nations, Inuit, and Métis peoples. And with that, I also would like to remind myself and everybody online of those who were forcibly removed and trafficked into Turtle Island as a result of the transatlantic slave trade, and the histories and the legacies of colonialism and new colonialisms which continue to impact Black people across the world. We recognize that racial colonial violence harms Black people, Afro-Indigenous, and Indigenous people in both common and very distinct ways. But more importantly, we also take the time to celebrate the joy, resilience, resistance, ingenuity, innovation, knowledge, and wisdom of Indigenous, Afro-Indigenous, and Black people on this land. Finally, we recognize our responsibilities as well as our obligations to actively work towards Indigenous sovereignty and Black liberation. And we offer thanks to our elders, past, present, and emerging, from whom we continue to learn. May their wisdom continue to inform our actions to a more just world. And with that, I would like to invite the 265 people who have joined so far to take a moment to reflect in acknowledging, recognizing, thinking through whose land you're on, and also beyond that to think about how the way we learn, work, live impacts either upholds or challenges the colonial systems that we are in. And I'm going to be sharing a link for everybody. You can look at it today or in the future. Native Land is an amazing Indigenous-led website that kind of grants you an understanding of whose land you're on. And as you're doing that reflection, I wanted to mention a few housekeeping items. The first being that in today's session, we wanted to just note that the audio, visual, as well as the chat features has been disabled for the session. However, we are really excited to hear your questions and comments, so please do use the Q&A function for that, and those will be addressed during the discussion segments of this webinar. I am really excited to introduce Dr. Karen Campbell, who is co-moderating for today's session. She is an assistant professor at York University School of Nursing with a background of public health nursing. Her research focuses on women's health, health equity, and she has particular expertise around preventing violence against women. She is also part of the leadership team for public health nursing, practice, research, and education program. Karen, off to you.
Thank you, Samia. I'm really happy to be here today, co-moderating and with you and representing the work of the PHN PrEP team in supporting public health nurses, their supervisors and managers, and the home visiting staff in the work that they're doing with families. It's my pleasure today to introduce the speakers for our presentation, Dr. Khrista Boylan and Dr. Kerri Bojman. Dr. Khrista Boylan is a child and youth psychiatrist and researcher at McMaster University, specializing in emotional dysregulation and suicide risk in young people. She's the medical director of the Child and Adolescent Ambulatory Psychiatric Services at McMaster Children's Hospital and leads research focused on improving care and outcomes for high-risk youth. Dr. Kerri Bojman is the clinical lead of the Community Psychiatry Services and team lead of the Borderline Personality Disorder Services at St. Joseph's Healthcare. She's a certified clinician through the Dialectical Behavior Therapy Linden Board of Certification, with extensive experience treating individuals with borderline personality disorder. Dr. Bojman also teaches in the Department of Psychiatry and Behavioral Neurosciences at McMaster University as a part-time assistant professor, where she supervises psychology students and residents and provides consultation to mental health professionals across various settings. I'm going to pass it over to Khrista, and please take us away. Thank you.
Thanks very much, Dr. Karen. And thanks to all of you for joining this morning, and also for the incredibly important work that you do in your role as public health nurses, doing frontline care in so many ways with patients, many of whom will have mental health concerns in the early years or months of pregnancy and raising little people. And borderline personality disorder, as many of you are here today to learn about, is an illness that is very real. It is very difficult to live with borderline personality disorder. And the main focus today is not just about that, but how hard it can be for moms who have BPD to raise a little baby in the midst of dealing with a mental illness that really affects interpersonal relationships and someone's ability to manage emotions as a core feature. One of the things that we know, that the purpose of pregnancy is to create a baby. I think everybody knows that part. Ideally, that happens. But the other part of it is to try to help a mom become a mom. And we all know how hard that is. That's why you do what you do. And it's much harder for women who have BPD to accept and live this role day to day over the different phases of becoming a mom in the early months and years. What we're going to talk about, I'll do the first two objectives today, and hopefully at the end, we'll be able to help you in your job to do this work. The first objective that I'll go over is the clinical presentation of BPD as a mental illness and how it might vary or be taxing on a new mother. We'll talk about what is known around the impact of BPD on the offspring, the babies in their early years. And then Dr. Bojman will talk about the clinical aspect of working with moms who may have BPD or have BPD. And that is around the skills that they may be able to learn and use to mitigate their own symptoms and the impact of those symptoms on parenting. And also to review evidence-based approaches for working with mothers and women that nurses may actually be able to use in their daily encounters with moms in the home. I thought I would start with a clinical example. These are, you probably wonder, what is a child and adolescent psychiatrist talking about this for? Well, as you might imagine, I have had many teen moms as well. So my lens is really on the up to the early 20s, because as you also may know, it's hard to get follow-up care sometimes for patients, so I'll follow them if they're really ill. And so I've seen some babies become toddlers of my patients. And I think the same is true really for women in their 20s, which is the decade where BPD is definitely most prevalent and most severe in terms of its symptoms for the patients. So Laurel is a patient, but it's not Laurel. She's a 21-year-old woman who just had a baby. She's now 2 months postpartum. And she is known to have BPD and social anxiety that she's had treated as an adolescent. She lives with her mom, and they're getting along now because they have a baby to focus on. Prior to that, it was a very hot and difficult relationship. And while the baby's well and the pregnancy was really uncomplicated, which is a treat, she is really struggling to breastfeed and is worried about this and worried about the cost of formula, which is very real. And then, of course, she's not producing milk because all she does is worry. And she enjoys this baby, but she can only think of him and is completely preoccupied around his well-being. So she's mentally exhausted. She's not sleeping, and she's fantasizing about handing him over to somebody at any given time because it's just too much for her. The guilt and the shame about her parenting, perceived parenting difficulties. And she used to take him out and do what you ask, but now she really is feeling very ugly and judged by others all the time. And so she's become much more socially isolated, and her mood has dropped. Fortunately, though, her suicidal ideation is at baseline, but she's self-harming a bit more now and is really feeling like her meds are not helping her anymore. So she's going through a lot. And then there's Andy. She's older. Her circumstances are different. Andy does have a diagnosis of BPD, but she didn't have a lot of treatment. And she is now 7 months pregnant and living with her boyfriend. This is a new relationship, wasn't a planned pregnancy, but she is really glad to be pregnant because it is actually quite common that young women get very excited about the idea of having a baby because a baby can be a constant source of validation. At least that's what many people think. And so she always wanted to be a mother, but she doesn't plan to stay in the relationship because it's really not the ideal relationship for her. And there's a lot of cannabis in the house. The dad's around a lot, not doing very much. But the good thing is you've helped her to stop or really cut down on her cannabis use. And so while she's excited to have this baby, she finds that all these relationship issues and struggles are getting in the way. And there's lots of concerning things in the relationship. There's yelling, there's hitting. She's left many times and come back. She's damaged property in her fits of dysregulation, and they're at risk of being kicked out because of these struggles. She is waiting for therapy at the local hospital, which you've helped to coordinate. And she is worried that she won't be able to do the therapy once the baby comes because it's time demanding for sure. So these are very real, very different patients with very big problems. And they both have BPD. And many of you know what BPD is because everyone knows what BPD is today because you can look it up on the internet. And there's lots of websites about it. But I'll try to summarize it as quickly as I can. It is a complex mental illness. It is fundamentally where the person has struggled for very many years, sometimes decades, with extremely intense emotions that come on very, very quickly. They are typically negative emotions, but they can be positive emotions. And this intensity of emotions and the experience of emotions affects relationships. People who have tumultuous and difficult relationships often experience rejections and losses of relationships, which become internalized as what we call fears of abandonment. And these fears of abandonment can actually become front and center for people with BPD because of their emotion dysregulation and their lived experiences of being rejected due to their behaviors and their needs. There are 9 different types of symptoms for BPD, and to have a diagnosis, you need 5. Most people do have 5 or more quite easily. This list of symptoms, you can see I've highlighted 3, and these are the 3 that you commonly hear about and see because they're visible to you. Most of the time, when I'm teaching people around diagnosis, I say, if you see these 3, if you ask about the others, you will find them. They are there. And it's really important not to miss this because this is a treatable illness. It actually is far more treatable than mood disorders. So that's the very positive thing about BPD. You can see in the list of symptoms, I've talked about many of them already. There's fears of abandonment. There's difficult, very intense relationships that are not stable and long-lasting. The woman often has identity disturbance, not knowing who she is or struggling with boundaries between herself and her baby or other people. There is impulsivity that can really impair, like things like stealing, substance use, spending money that they don't have. And all of these are to help regulate emotions. And then there are the common symptoms that people know about, which are suicidal gestures or threats to end their life, and also suicide attempts, which are really hard to deal with. And then there's emotion instability, feelings of emptiness, very extreme outbursts of anger. And sometimes people can actually be quite paranoid and suspicious and have a terrible time trusting others. So as you can imagine, this is a tall order for the woman who has BPD or the man, but we're not talking about men today. And it's also really difficult to know how to be helpful when all these things are going on for someone. There is a theory about why this happens. And it was put forward, it's called the biosocial theory, and it was put forward by Marsha Linehan, who is an incredibly talented clinical psychologist who herself also lived with BPD and experienced long hospital stays. And she figured out ways to help patients therapeutically. And the model is, as I mentioned before, that people struggle with very intense emotions early in life. And they experience, because of this, they experience a lot of relationship problems and feel very at risk of abandonment because it actually happens to them. And then it's a vicious cycle and very difficult to separate the emotional experience from the fears of abandonment. So people experience struggles throughout life. And as you can imagine, if you're a woman that has this and there's a baby that is very demanding and sometimes not very validating, it can create struggles in the mother-child relationship because of the fact that mom has BPD. It is a very genetic condition. Women who have BPD usually have a parent with BPD or a sibling. There are known brain differences. I won't get into all the details, but one of the ones that's really important to remember is that people who have BPD do look differently at facial emotions, and they do interpret neutral emotions as quite negative. So they are people that are often on alert, especially in new relationships, to look for potential signs that they're not liked or that they won't be cared for by that individual. And you may experience that as a clinician working with the woman. And because it's highly genetic, there's also a lot of intergenerational trauma that can be experienced because if this mom's mom had BPD, then she may have actually been parented in a very similar way that she's at risk of parenting her baby. And babies are great, but they are really scary. I think many of you are very well aware of this and use this in your model of helping women adjust to parenting an infant that has a lot of needs. That's very hard to read a lot of the time. It doesn't go, yay, mom, you're awesome, because babies don't do that. And these are all demands on a woman, let's say, who is very vulnerable and worried that this baby won't like her or that she will not be a good parent to this baby. So the normal parenting worries about being a good enough parent are on steroids for women who have BPD. I don't want this to be all negative. It actually now sounds quite negative. It isn't all negative, but it does. What I share this to you to validate your experiences and help you relate to some of the things you may be encountering with your moms that you're working with. As I mentioned, BPD is also more common during the 20s and early 30s. It does seem to reduce when women enter stable relationships. And sometimes after they've successfully navigated caring for a baby, it can actually be very therapeutic for a woman with BPD because they've developed a successful relationship if that happens. But moms who have BPD are much more likely than moms who don't to have these specific problems. And there's a reasonable amount of research about this. The moms are more likely to be raised in homes where there was BPD. They do not trust their caregivers as well. They have maybe a history of multiple types of abuse. They are more likely to have an unwanted pregnancy or to be experiencing intimate partner violence. They are more likely to have lower financial resources because of the impact of their illness on their education and educational opportunities. And they are more likely to be using substances at the time of conception. So it is a very important public health concern. As you know, patients with BPD will often use acute care resources a fair bit, even though they're connected to you. And this isn't always a bad thing, but sometimes people learn that physical concerns get more medical attention than mental health concerns. And so it can be kind of difficult to support the care or lead the care as an individual with someone who's anxious and has BPD. And as I mentioned, it's very common. So in obstetrics clinics alone, probably 20 to 30% of moms have BPD. And I'll tell you that this is important for another reason. And I think my next slide is about this. So it's about the impact of both depression, which we know a lot about in the postpartum period. I'll talk about that, but also the fact that, oh no, I'm actually talking about it here. My apologies. Postpartum depression is a lot more common for women who have BPD. So it's known to be at least twice as common. than it is in moms who don't have BPD. And about a fifth of moms who have BPD do require acute psychiatric intervention during their pregnancy. Most of the time, that is because of suicidal thoughts, attempts, or related behaviors, because that's the main reason people go to hospital when they have any mental health disorder. And also, moms with BPD are more likely to experience pregnancy complications. The logic behind this is that women with BPD tend to become pregnant when they're larger physically. They may have obesity already, or they may be experiencing some of these diabetes-related side effects from some of the psychotropic medication that they may be on, which is very unfortunate. So they go into pregnancy at risk of all of these outcomes, and indeed they are greater likelihood of having outcomes related to gestational diabetes and perinatal complications for the fetus and preterm birth. Actually, moms with BPD are more likely to want cesarean sections as well because of their history of sexual trauma. So that's another interesting struggle that they have. And the impact on the baby, I don't want to be overly negative about this, but the take-home message in this area is that we know that moms with BPD struggle a lot to be emotionally consistent and available, non-threatening, and able to tolerate their own insecurities about parenting than moms who do not have BPD. Studies have looked at this in observations, where they're videotaping and coding the mom-baby interaction. And then also looking at that interaction when kids are older and toddlers, or even measuring outcomes into early adolescence. And these studies show a similar finding where that moms with BPD or a lot of BPD symptoms are more likely to engage in what we would call maladaptive emotion-focused difficulties with their babies. So when their emotions are dysregulated, it leads to changes in the way they interact with the baby. Most commonly that they can be very intrusive and not able to follow the baby's cues. So if the baby wants to withdraw and self-soothe, the moms will take that as an indication that the baby's not interested and may try to entertain or engage the baby more than is needed. And they can also interpret some of the baby's cues as negative and can be punitive, either withdrawing things from the baby like toys or things that would help soothe them because they feel that the baby's angry with them. And these are really unfortunate things because they do absolutely affect children's emotional development, as there's so much research now showing that this type of behavior is harmful to the developing nervous system. And finally, on my end, is about postpartum depression. Because it is so much more common, we have to be very worried about it. But the other part is true that women who have postpartum depression may also have BPD, because the two of them go together a lot. And so we have to think about screening for depression in women with BPD, but we actually have to do the opposite as well. And the thing that's really important here is that studies are showing that when you actually look at the impact of BPD symptoms, they're much greater on children's mental health outcomes than the mom's depression symptoms on their own. And in fact, the studies that have tried to understand why BPD symptoms are so important for children's outcomes, these studies have found that it's actually the way that the moms parent, how their thoughts about their child affects their parenting that predicts the children's mental health outcomes. So where the future needs to go, in my opinion, really is looking at how do we support parenting, anxiety, and also coach on those types of behaviors that women are maybe more vulnerable to displaying with their infants as a way of helping the moms, but also preventing mental health difficulties in their children. And at this time, I'm excited to hand it over to Dr. Bojman to talk about interventions.
Thank you so much, Dr. Boylan. So at this point, we're switching gears and we're looking a little bit more at the clinical realm. So what do we know in terms of treatment? So we know that there is good research on psychological treatments for BPD. So we have dialectical behavior therapy, schema-focused therapy, mentalization-based treatment, and transference-focused therapy. And we know from the literatures, most research has recruited participants based on their diagnosis. So what this means is limited research has actually examined specific interventions for mothers or mothers-to-be with BPD. So what's started to come up recently as an avenue for intervention for this particular population is dialectical behavior therapy. So as Dr. Boylan mentioned earlier, DBT was developed by a psychologist named Dr. Marsha Linehan. And it was developed for chronically suicidal individuals with a diagnosis of BPD. So I'm just going to flip back to this slide here. And we touched upon that BPD, the development of it and the maintenance of it was explained by biosocial theory. So we have this biological component and this social component. And for the biological side, we see that individuals are more vulnerable to difficulties regulating their emotions. So they're more sensitive to their emotions. They have higher reactivity, which means they experience their emotions more intensely. And these aversive emotions are longer lasting. So it takes a longer time for those emotions to return to baseline. For the environmental side, the key word here is invalidation, and specifically pervasively invalidating environments. So invalidation communicates that the person's experience and their emotional response is incorrect or not to be taken seriously, or it could be dismissed. So this becomes a problem when you have someone who's biologically vulnerable to emotion dysregulation in this pervasively invalidating environment. So we talk about like there's this poor fit between the person and their environment, such as the environment can't communicate to the person an understanding of some part of their experience, which leads to greater emotion dysregulation. So what we start seeing happening is the environment may inadvertently teach the person that in order to be understood and get their needs met, they may actually have to escalate that emotional expression. Or conversely, the person may learn, hey, there's no point trying to kind of communicate how I'm feeling or get my need met in the first place. So they may actually learn to shut down and detach from emotions. So we see this core problem is emotion dysregulation, which is this real difficulty changing the experience or the expression of the emotion. And these maladaptive behaviors that we see in BPD, such as self-harming behaviors or suicidal behaviors or substance use, many times they function to regulate the emotion, such that the person can avoid or escape from that really aversive experience. And other times, these behaviors are the consequence of failed regulation. So if we think about someone with anger discontrol, if they can't inhibit acting on the urge that goes along with anger, we might see that maladaptive behavior. So the assumption in DBT is one of a skill deficit model. So what that means is clients are unaware or they might not have access to certain skills that would help them regulate their emotions. And in DBT, clients are explicitly taught these skills to regulate their emotions. So they typically go to group once a week. That's set up to be much more didactic, like a classroom, as opposed to a traditional process group, where clients are taught skills and then practice them for homework. So a small number of studies suggest that learning DBT skills may be a helpful intervention for mothers and mothers-to-be with emotion dysregulation and or BPD. So one recent article has found that learning DBT skills reduces emotion dysregulation in the perinatal period. Another study has found that learning DBT skills decreased BPD symptoms in women with at least one child under the age of 3. So in thinking about what skills could be helpful for mothers with BPD to practice to mitigate the impact of their emotion dysregulation on their infants, the following skills could be helpful. And these are suggestions, once again, as we know there is limited research. So all of the skills are from the DBT skills kind of training, handout, and worksheet. So they're taken from this particular manual. They were chosen because in the literature that I've seen, they've come up in the interventions to date. These particular skills are quite behavioral in nature, so they're quite straightforward. And they also target high intensity emotions and mood stabilization. So this list by no means is exhaustive. And my thoughts are it might be a helpful place to start. So the first subheading says distress tolerance. And distress tolerance is a module in DBT. And the skills that are listed below come from the first half of this module, where the key goal is how to get through a crisis situation without making it worse. So all three of the skills listed under distress tolerance, stop, tip, and tip, my apologies, the first two are acronyms, where every letter stands for a different step that the person would take when performing that skill. So if we start with the stop skill, the goal of the stop skill is to refrain from acting impulsively. So the S would stand for stopping. So we would teach clients to kind of freeze all their muscles, to glue their tongue to the roof of their mouth and then close their lips if the urge is to yell or to act on anger verbally. So we teach them this first step is really just to stop. The T stands for taking a step back, so in your mind's eye or physically. The O, we teach clients how to observe what's going on around them or inside of them to gather information. And the P is about proceeding mindfully. So we would teach clients to think about what do they have to do in line with their goals. The tip skills have to do with directly changing and targeting body chemistry to lower arousal. So we talk about temperature, intense exercise, paced breathing, and paired muscle relaxation. If we zero in on paced breathing, what we're doing is teaching clients how to slow down their breathing and in fact, how to breathe out for longer than breathing in to activate their parasympathetic nervous system to assist with emotion regulation. The third skill that's suggested is self-soothing. So self-soothing is learning how to do things that feel comfortable, that can help with stress or pain, to help get through that period of time without acting on any urge to make anything worse. And the last kind of bullet listed below says emotion regulation. And this is a different module that really focuses on how do we reduce emotional vulnerability and build our overall emotional resilience. So one skill we talk about here is called the PLEASE skill. And PLEASE is also an acronym where every letter stands for another way we can take care of our body to, as we call, take care of our minds. So decrease our emotional vulnerability. So for PLEASE, we talk about physical illness, eating, avoiding mood-altering substances, sleeping, and exercise. So it helps give us an in to see if we could target any one of those areas, can we support this person in increasing their emotional resilience? So if we go back to our example here for Andy, anything that's highlighted in red are possible indicators of BPD symptoms or emotion dysregulation. So for example, we might see kind of impulsivity coming up. If for example, damaging property, maybe that was an impulsive action, or maybe that related more to anger discontrol. So we start kind of pulling out from this example, possible indicators that we could start targeting with intervention. So if we zero in on the yelling, so the behavior of yelling, here's an example of how we could map on the skills that we just reviewed to this target of yelling. So if we go to stop, we might teach the client, for example, how to freeze in that moment and how to position their mouth and their tongue to avoid expressing what they were going to say. And maybe we're going to help them thinking about, if they were to proceed mindfully, what do they need to do? Do they need to go to their bedroom and take a time out and a break before coming back and interacting with other people? Another example here we can focus on could be, for example, self-soothing. So maybe we support the person in thinking about, what do they need to feel more soothed in the moment? Is this comforting music? Can they put on a scented lotion? Is it a warm bath? So supporting them in thinking, how can they get some feelings of comfort while they're tolerating that crisis period? So until now, we touched upon some skills that Andy can use. We're going to be switching gears now and really discussing approaches that might be helpful for you to use in working effectively with your clients. And the first suggestion comes directly out of the biosocial theory. So we know that invalidation increases emotional arousal. So that is why our first suggestion is validation. And validation is considered to be a core strategy that is used in DBT. So as defined by Linehan, validation is when the therapist communicates to the client that her responses make sense and are understandable within her current life context or situation. So this is so important because when we validate someone else, we help decrease their emotional arousal, which in turn allows the other person to more accurately express their experience, which in turn allows us to help manage or solve the underlying problem. So validation becomes so important, especially when working with this particular population. So we can validate using words, or we can validate using behaviors. So with words, we're communicating why some aspect of their experience makes sense. So we say things like, it makes sense that, or it's understandable that. We can also validate behaviorally. So if someone says they're thirsty, we might go and get them a glass of water. So behaviorally, we're indicating an understanding of their experience. So if we go back to this example of validating Andy, I just pulled this sentence from the vignette. While she's excited about the baby, she finds all the relationship issues with her partner to overshadow her joy. There's lots of yelling and she hits him. So the question is, well, what do we validate here? So we validate things that are valid. And it could be any number of things that we would validate. We could validate emotions, urges, actions, thoughts, efforts. Maybe someone's suffering is something that we validate. So in this particular vignette, if we're talking to Andy and Andy mentions like the stressors are overwhelming, if we're going to validate with words, we might say something like, no wonder you are so stressed. If she's talking about her relationship with her partner, and she's expressing why she's so angry, we might say something like, it makes sense that you felt angry. Sometimes clinicians say that they're not quite sure what to do. So they know that they want to validate, but they don't really know where to start. They don't know how to use words or behaviors. So I really want to emphasize that simply mindfully being present and paying attention is a form of validation. So we're communicating this understanding of the other person's experience, perhaps non-verbally, perhaps by nodding or making eye contact. So that in itself is validation. So if you are doing that, you already are using this skill. Adding on the other parts to it is just an extension of using validation. So the second suggestion about regarding approaches during home visitations is to look to practice guidelines. So guidelines are typically based on reviews of published evidence, and usually there's expert opinions of some kind of working group. So in looking at guidelines for BPD in the perinatal period, I was able to find two. So both come out of Australia. One is called the Best Practice COPE Guidelines, and one is called the South Australian Perinatal Practice Guidelines. And I just pulled a few examples and summarized these examples from the guidelines. So the guidelines can be really helpful in terms of directing care or providing psychoeducation about where to go and how to assess when you're doing home visitations or working with this particular population. So, for example, one suggestion at the bottom of the COPE guidelines says to listen, reassure, and provide education. So education could be related to, for example, developmental milestones. So moms having that information could really help normalize for them, oh, if my infant or child is doing X, Y, and Z, that's actually developmentally appropriate. So it might actually change their interpretation of their child's behavior. So these are two that I have found specific for this particular period. The third suggestion is to seek additional training and support. Many people find knowledge is power, so the more we know and the more prepared we feel going into a situation, the more competent sometimes we feel in that situation. So options could include continuing education on BPD, training in evidence-based treatments. There's also training for good psychiatric management for borderline personality disorder. This is a flexible, kind of more generalist, structured management approach. It's a low intensity training course. And quote unquote, it's good enough to be implemented by most general clinicians with the motivation to provide good care for patients with BPD. So it really draws from this case management model, and it's less intensive for both the client and for the clinician in terms of training and resources. So in summary, Dr. Boylan and I, when we met to talk about our presentation, we were thinking, what do we really need to say to kind of summarize the information we have to date? So number one is just your job is hard. We know this can be really challenging work, particularly with limited research and interventions available. So we want to emphasize there is a limit to what you can do with the resources available. And as Dr. Boylan said, and this really sucks, and I totally agree. So that leads to our third point, which is ensuring to work within the scope of your role. We know many times clients present with these multiple intertwined problems, and this can feel really overwhelming. So we encourage you to be mindful and recognize you're a key player in this person's treatment plan. And sometimes it does take a village to address all these other areas of concern. So we encourage you to continue to consult with your colleagues and engage in your own self-care when feeling additionally burdened. And our last point here is also, and importantly, that your work is important. You may be the primary source of support for that family. You have a really pivotal role in managing that patient's care. And you also may be that person's introduction to the mental health care system. So this is really, really important work. So on that note, we want to thank you all for attending this presentation, and we hope you've been able to share some information that could be helpful in your practice. So at this point, I will be turning things over to Karen.
Thank you to Dr. Boylan and to Dr. Bojman. That was an excellent and insightful presentation. I learned a lot, and so much of it actually made sense within the context of what we do as public health nurses. We're going to move on to the question and answer segment and answer some questions from our live audience. A quick reminder to everyone, if you haven't already, and I do see some questions coming in But please feel free to go to the Q&A pod and put your questions directly in there. And I'm going to start by asking our guests this question that comes from Healthy Babies teams that already are trained in CBT or cognitive behavioral therapies to provide that in home. Are there any considerations or any contraindications when using CBT with DP clients?
So, DBT comes from the CBT tradition. So it's really like a form of cognitive behavioral therapy with a whole lot of mindfulness and validation and acceptance strategies added onto it. So there's going to be overlap in terms of strategies that clinicians can use. So the cognitive strategies, the behavioral strategies. And so just from like a clinical perspective, I can't right now think of contraindications. I don't know what like the research says about this, but just from that perspective there, I could see how some of the interventions actually could be quite similar as DBT draws from CBT and its historic roots.
That's really helpful. I think you touched on this issue, but this specific question is around any advice that you have for boundary setting. So this nurse says, I'm struggling with a client who calls frequently in crisis.
What I was going to add to Dr. Bojman's previous comment is that whatever we do therapeutically, like if you're thinking, I'm going to approach this to do some kind of evidence-based intervention for this woman's struggles, you need to be really careful that you know what you're going to help them with. And they need to identify what they want the help with. The reason that I love DBT is that it helps with risky things. It helps with things that directly get in the way of personal safety, either, you know, self-harm related things or aggression or anger directed towards others. What I would say is that, you know, there are many women who do not have those problems and they have BPD, and so that's fine. But if you have a client or a mom that you're working with that has some extreme risky behaviors, like I'm going to kill myself or that kind of stuff, you actually, that's the boundary. Like you have to focus only on that until they're not getting in the way of your daily work with the person. Because then not only are you biting off more than you can chew, but you're actually not going to be helpful. Because if you have a client that is talking about ending their life or calling you like outside of you know what you would expect, then you have a boundary problem there. And that's the only thing you need to work on until you don't have that boundary problem to deal with. Now, Kerri, I know you can add more to that, but I know I always think about what's the hierarchy that I'm working under with this person, you know. Am I worried about the safety of the baby? Stay on that. Stay on that until that is not an issue. Don't take on other stuff because that is like the fire in the house, right?
Yeah, that is such a great point. And this is for the question about kind of boundaries with clients, correct? Yes. I totally agree. I think some things that have been helpful for me relate to being really clear about what my role is and what my capacity is. Being really clear on exactly what Dr. Boylan said. So if someone presents with like acute risk, what intervention matches that risk, and not to be pulled into solving any other problems that may be going on as well. So what I find really helpful for setting boundaries is one, starting with a really good, transparent orientation with the client. So letting them know, these are my limits. I want to be here for you. One of my limits is I'll take your call, but I may not take your call past 4 p.m. when I leave the office. So everyone is really clear about if you're going to contact me, if I'm going to contact you, how do we structure this together so we're both on the same page? And I find that in itself is just so helpful, that orientation to prevent those future boundary challenges that could come up later.
Yeah. That part, and I want to emphasize that that is actually treatment. Like you are really helping that person by letting them know that you can only do this much. Like you don't have to do the word only, but this is what I do. I can do that really well, and I will not disappoint you on that. But if you expect me to do these other things, that's not like we could actually run into trouble. There may be other people that do that other stuff, right? But that is actually helpful because it reduces that fear of abandonment, and it helps the person feel like, okay, they're going to help me with this thing, right? So that you actually do a good job at that and not do too many other things that you just can't do it all. You can't.
We can't. We wish we could, but we can't.
Absolutely.
This question might actually dovetail nicely off of what you just said, Dr. Bojman, about being transparent. So any suggestions that you might have on how to raise concerns with clients where the nurse may suspect BPD, but there hasn't been a diagnosis?
That's an excellent question. It's almost a bit of a philosophical question about diagnoses and the purpose of diagnoses. I think many times a diagnosis is helpful because it allows the person to understand their own experience, and then it allows them to actually get the support they need from that environment that may be invalidating them because the environment doesn't understand where they're coming from. So I think in that particular situation, I might recommend perhaps an assessment here could be really helpful because it seems like you're struggling with X, Y, and Z, and it's really interfering with your functioning. So why don't we talk about pros and cons of doing an assessment and make a really informed decision together, whether this is something that you believe would be of benefit to you. So I think, unfortunately, BPD still carries a lot of stigma. And there's a fear on the part of some healthcare professionals to make that suggestion. And I think there's also stigma just among also clients who have received treatment because they have BPD and they were treated in this way as well. So I think stigma is something that people tend to fear across the board. But I think when we present, what does this label actually mean? It's like a cluster of behaviors at this point in time. It's not a life sentence. And we're really compassionate in that delivery. That can be really helpful.
Along with that, somebody has asked in the questions that you present this also to the Child Protection Services because it would be so helpful for them to have this information and address some of that stigma as well. Maybe not you, but hopefully they will get that. Dr. Boylan, I think this might be a good question for you, given that you're talking about transitioning your patients or clients out. One of the nurses is asked about ending the therapeutic relationship. So oftentimes the clients will age out of our programs around the time that their babies are around 2. So any tips on ending that, knowing that the client is still in crisis?
Yeah, no, that's a fabulous question because Kerri and I experience that all the time, right? And people who are not doing like a time-limited intervention have it worse. I'm not saying that helps you, but it does in the sense that you do have a mandate to deliver care in a certain period of time. So I don't want to sound preachy because I know you do this anyway. Like you have to start at 18 months. Like people have to be reminded, especially when they become extremely attached. And oftentimes we find that people regress when they know that the relationship is ending, especially if it's a very important relationship for them. So as therapists, we expect people to actually get worse as they are approaching the end of a time-limited intervention. So what does that mean? Well, you can expect that, and that actually doesn't mean that they are worse. It doesn't mean that. Like to Kerri and I, right? To you, it may be that they are worse. Maybe there are new things going on, like anything new. So I don't want to say that just ignore it if it's getting worse, but you do need to know that it does get worse. The other part of that is that, BPD probably is a multi-year treatment. The evidence-based treatment is at minimum 20 weeks, at minimum 24 weeks, right? And that's at minimum, and most people need twice that long to get treatment. So we're looking at a year and a half of active treatment. So it's unlikely that people are going to be better in those 2 years postpartum substantially. So I might just suggest that you have to be thinking that they do actually need to access psychotherapy, evidence-based psychotherapy, and you can work at that whenever you can start working at that. And God forbid it's not available in the area where they live, which is a whole other level of concern that varies depending on the nurse where you're working. But you kind of have to say, oh boy, I've had a year of being really, really heavily dependent on, and my mom client is not generalizing these skills. Like, she's really stuck. She needs treatment for BPD. Like, that's kind of a no-brainer. And the challenge there is, how do you get her to do that? I know you guys have many skills in connecting people to local resources, but you kind of have to accept that that's what you're going to need to do, and it will get worse before it gets better.
Thank you. A few people have asked questions around helping with a client that may be withdrawing. Another nurse has said that she has a client that's attending DBT and says it's boring. So how can the nurse help to support and motivate her client, and what to do whenever clients are withdrawing?
Yeah, I mean, I've heard that before. So in good company here with the, I don't want to go to group, I have to go back to group. So 2 thoughts about this. One, it's really helpful to know what the person values. Like, what do they want their life to look like? Because that becomes the carrot for all of these changes that are so hard to make. We're asking people to do behavioral change. That's one of the hardest things we can do. So I think if we know where the person wants to go, we can help them see how, even right now, if they're doing this one thing, how it's going in that direction. So we call that like their life worth living, and we set goals in that area. So that's the first thought that comes to mind. The second is really validating. Yeah, going to group can be boring or frustrating or anxiety provoking. The way I like thinking about it is you go to group and you learn a skill in isolation. So it's kind of like learning one letter of the alphabet. So if you learn one letter at a time, you're like, well, what do I need like a W for? Who cares? But then over time, when you start figuring out how these letters put together, you're like, oh, I understand now. Now we can like write a script, we can write a story. So I think like psychoeducation coupled with a lot of validation about how sometimes group feels like, boring or difficult, can be helpful in that regard.
Fantastic.
Mm-hmm.
Some of our rural colleagues are asking about what to do whenever there's no services that are available to them. And are you aware of any virtual options?
So I'm trying to I believe so. I believe throughout COVID, there has been a real shift to also trying to kind of disseminate interventions also and treatments virtually. So there are actually, I think most like public clinics I can think of have virtual options. It might take some Googling to find them, but I am fairly confident that they are out there. I know, Dr. Boylan, if you.
I really don't.
Yeah.
Just because of the world that I work in.
Yeah.
But one thing I would say, and this is not for women who have lived experience, but it's for family members. There's a fair number of support groups for families that are organized well, like that have an evidence base behind them, that have a structure to run them and that kind of thing. And one of them is called Family Connections. Like, it's just Family Connections. I don't know if it's .org or what it is, but it's like definitely throughout the world. And like, for example, there's 2 within driving distance here, and people call and they ask to participate in these family support programs that provide a lot of education, but also provide direct support, peer support largely for people caring for family members with BPD.
It's excellent. Thank you so much. there are so many questions that are left. I'm not at all surprised that so many of these came in, and we can take that back to PHN Prep, and perhaps we can work with Dr. Boylan and Dr. Bojman to answer some of your questions about BPD and how to even look at BPD and how that's different than bipolar. Those types of questions have been coming up. So hopefully we can work with you and see what kind of resources we can provide for nurses going forward. But as we wrap up today, I would like to give my sincerest thanks to both Dr. Khrista Boylan and Dr. Kerri Bojman for presenting this really needed and really insightful presentation. I'd also like to thank my colleague Samia Abdi for co-moderating with me, and of course, a special thank you to everyone who joined us today for this webinar. We really hope that it helps in your practice. You can expect to receive a brief anonymous survey for today's session. Please try to complete this as it helps us to improve our programming. And thank you. Have a wonderful day.